All right, thank you for those three outstanding talks. And I'm now joined by two of our hepatology experts, Dr. Alan Bonder, Dr. Michael Curry. Dr. Pratt, unfortunately, was not able to make it, but as I said, we're lucky we have two other experts who can actually handle all of the other PBC and PSC questions. So let me just get started here. I'll start with Dr. Bonder with a couple of questions here. There's a question here. Would you consider drug-induced autoimmune hepatitis in a patient who has been on drug for more than a year? Example here is interferon for infliximab for Crohn's disease. And would you try to stop it?
Great question. I think, in those cases, we kind of a thorough workup, including maybe a liver biopsy and, autoimmune markers to see if those people have the presence of those, or with the biopsy show like plasma cells or kind of histologic features of autoimmune hepatitis, then what I would suggest is autoimmune, drug-induced autoimmune hepatitis, and I would stop the drug and treat it as autoimmune and recommend the IBD person who's managing that patient to switch him to a different agent. So that would actually, and then we'll make improve his liver test.
Okay. And there are a couple questions related to sort of just, keeping patients on low-dose prednisone. So here's a question about, for an autoimmune hepatitis patient treated with azathioprine and prednisone, do you ever keep patients on a low-dose prednisone at the end of the taper, maybe 5 or 10 milligrams for 6 to 12 months before stopping the prednisone completely? Parentheses here is for cases where normalization of labs is achieved, but just hard to taper off the lower doses.
But we do have a subset of patients that unfortunately will have to stay in low-dose prednisone. And again, kind of the importance part of this answer is the question is the patient on remission? If the patient is on biochemical remission, some patients flare up even when I go down from 7.5 to 5 milligrams of prednisone, and I do keep those patients in low-dose prednisone. I think the question of switching into a different agent, it's always a possibility, but again, I want to make sure that those people still flare if you, for example, switch either azathioprine and 6-MP to mycophenolate. So again, I just want to throw out there that, between 10 to 15% of my patients will stay in some type of low-dose prednisone, and that low dose is between 5 to 7.5 milligrams a day.
Okay, terrific. Thank you. Dr. Curry, so here's in a patient with suspected ICI, drug-induced liver injury, do you wait for the workup to come back, checking hepatitis serologies, ANAs, et cetera, or do you just start steroids if your level of suspicion is high?
Great question. I will tell you that most of the patients we see, these are frequently been seen by the oncologist who's recognized the abnormal LFTs, and a lot of times these patients are already on steroids. In patients, if they're not on steroids, if we take a good history from them and there's a low risk that these patients could have a viral hepatitis, then we agree with continuing these patients on steroids, but getting that workup going straight away. And in patients with more severe disease where they're not responding to steroids, or if they have a grade 3, grade 4 injury, then in that situation, we would move pretty quickly to biopsy, even sometimes without serologies being back.
Okay, great. Thank you. So, Dr. Curry, I'll ask you one of the cholestasis questions here. So if a patient has chronically elevated ALP phos with negative serologies, would you recommend a liver biopsy?
I would. In these situations, first and foremost, you want to make sure that the alkaline phosphatase is coming from the liver, so get that gamma GT 5 nucleotidase or fractionate those ALP phos levels. But if they are liver related, then I would move towards liver biopsy in these individuals. Now, if it's a patient who is reluctant to undergo liver biopsy, is elderly or has had a lot of other comorbid diseases, you might, and you have availability of transient elastography. If it's a minimal elevation in ALP phos in an asymptomatic individual, you might get a transient elastography. And if there's no significant disease, that's a person that you could probably monitor. But a young person without comorbidities or without risk factors for complications of a biopsy, I would move towards biopsy.
Okay, and so just kind of, if I just follow up on the kind of related biopsy question, so would you recommend a liver biopsy at the time of diagnosis of PBC, or is the ALP phos, AMA, and FibroScan enough?
Great question. Again, So it's not essential to do a liver biopsy in a patient who has a positive anti-mitochondrial antibody and other clinical or biochemical features of primary biliary cholangitis, but it is essential to stage their disease to make sure that they do not have advanced fibrosis. So liver biopsy is not absolutely essential in these situations. There is one caveat, and that is that there is a small percentage of patients with PBC that have a coexisting condition called nodular regenerative hyperplasia, a non-cirrhotic form of portal hypertension. So therefore, if you're not going to do a liver biopsy in these individuals, you may want to opt to do an endoscopy on them at least once to make sure that they do not have esophageal varices or other secondary signs of portal hypertension.
Okay, that's great. So Dr. Bonder, so this is kind of a follow-up, kind of the question before. So if you have an elderly patient with autoimmune cirrhosis on azathioprine maintenance treatment, they're on 5 milligrams of prednisone to maintain normal transaminases after 3 relapses. Would you consider some other second-line therapy or just maintain the low-dose prednisone?
I would just maintain the low dose prednisone. Again, as I explained in the prior question, and there is a subset of patients that will need some type of low dose prednisone to keep them in biochemical remission. And again, just another reminder that frequent flares puts those patients at risk of increased fibrosis and complications of liver disease for the future.
Okay, great. There's a question here about at what age do you stop checking anti-LKM antibodies in your screening?
I mean, that was a great question. I don't have an age cutoff. If you look at the literature, there is some people like ages 50, 52 that actually had autoimmune hepatitis when then the markers came back positive for LKM. So if it's a new workup, I do send it. Again, if it's 70 or older, it's very unlikely to come back positive, but I still send it. I don't recommend, or I would not recommend any age cutoff for just screening for this type of markers.
Okay, great. Dr. Curry, so this is a question about drugs for PBC. So is obeticholic acid or benzofibrates completely contraindicated in people with compensated cirrhosis, or can you just adjust the dose of the drug?
Dan, I'm sorry, you cut out there on me.
Oh, I'm sorry.
Would you mind
Okay.
rephrasing that?
Yeah, so the question is whether in someone is obeticholic acid or benzofibrate completely contraindicated in cirrhosis, or can we adjust the dose of the drug?
Well, first and foremost, so neither of them are contraindicated in cirrhosis. However, Ocaliva or obeticholic acid is contraindicated in patients with portal hypertension. However, in patients with cirrhosis, you do need to adjust the drug of Ocaliva, the dose down. So neither are contraindicated in cirrhosis, it's just portal hypertension.
Nice. Okay, great. So Dr. Bonder, in a patient who does not tolerate azathioprine but achieves remission with cyclosporin only, would you add MMF or can cyclosporin be sufficient?
I mean, cyclosporin is not pretty kind of a frequent use medication to induce biochemical remission. So if they do not tolerate either azathioprine or 6-MP, I do go to MMF mycophenolate. I think as you heard in my presentation, and now there is data that comparing mycophenolate versus azathioprine, and then they did a randomized trial, and actually mycophenolate show better achievement of biochemical remission at 26 months after starting therapy. So I'm switching all my patients to starting an MMF before I actually go to any other type of drugs.
So this is another question about an AMA. So if you have a patient who has a positive AMA and normal LFTs,
there is two schools of thoughts in this. If you look at the AMA positivity, you do have a 20% risk of actually developing PBC histologic or symptoms. So I usually ask my patients is like two things that we can do. We can preemptively start UDCA or so to treat the PBC, or you can wait and get your liver test tested every 6 months or every year. And if the alk phos goes up, start treatment. But I would say that AMA is very specific and very sensitive for PBC. So those patients are an increased risk of developing PBC in the future.
Okay, great. Thank you. So Alan, there's a question here about, so patient with autoimmune hepatitis or overlap syndrome cirrhotics who develop cholangiocarcinoma, do you continue immunosuppression or stop or decrease it?
So my guess is this is an overlap between AIH and PSC. So the answer to the question is yes, I would continue immunosuppression because, again, a flare of those patients can put those patients at risk for liver failure, progressive liver disease. I think they need to be worked up for transplant because of cholangio, as long as this is within criteria for transplant, but that's a different ballgame. But again, yes, we'll keep those patients in immunosuppression as long as they have a diagnosis of autoimmune hepatitis.
Okay. All right. There's a question about strictures. I guess PSC. Do you need to stent asymptomatic strictures with no history of cholangitis?
Great question. The answer is we preemptively try to treat those patients as much as possible because yes, those patients are at risk for developing cholangitis. So stenting could be metal, plastic stent, depends what the endoscopist is seeing at the time of endoscopy. But yes, I would recommend stenting those patients, make sure they don't have any malignancy because everyone knows that PSC is a pre-malignant condition and you want to make sure that those strictures are not really a cholangiocarcinoma.
Okay. Couple last ones here. So putting you to work here, there's autoimmune hepatitis with and without cirrhosis. So do you define biochemical remission the same way?
Yes, the answer to that question is yes. So that's a normal ALT and a normal IgG. That's the definition of biochemical remission in cirrhotic and non-cirrhotic patients.
Okay, and this next question I'll ask you, but I'm sure we can save it for our next fatty liver session. But does NAFLD give you isolated ALK phos and GGT? Can that do that?
Yes. And when we see that, we do see a lot of overlap between autoimmune hepatitis, PBC, or even PSC. And then when you look at biopsies, for example, up to 30% of people with AIH would have underlying MAFLD or MASLD, as we call it now. Same with PBC. And then, I think this is when the biopsy is very useful because if the biopsy shows a lot of NAS activity, MASL activity, so that we can say to those patients that, you need more lifestyle modifications instead of treatment for the AIH or the PBC or the PSC.
All right. Terrific. All right. Well, that's great. We got through all of the questions, and I want to thank all of our speakers, Dr. Pratt, Dr. Bonder, Dr. Curry, for a fantastic session. We will go to our first morning break, and then we'll come back at 10:45, where we'll talk about alcohol-associated liver disease as well as NAFLD. And thank you again.